keep sharing them in the, oh, good idea. Tamara, record us so that others can join us even after. Ooh, Chrissy, I like that one. That's a good one. So throughout our time together, please turn into avatars, share cookies if you have new ideas, and it helps us continue to get to know each other better and connect outside of the very important work that we're all showing up here to do. And I'm going to count that as our mindfulness moment with Deshanta's niece, because that was amazing. I think there's still people showing up in teams, so hopefully we can keep with that message going that they can join us over here. So Anna, not to put you on the spot, but do you want to give an update on the safety work group, the report, and sort of any invitations for next steps?
Sure. So sorry, I was not prepared at all to do this, so forgive me if I'm a little hitchy. So the safety work group report was shared on the System of Care Advisory Council website in May, and it is available there for you all to review. We are moving into a phase where we're looking for some focus groups of family folks who have had youth who have either experienced residential care or needed residential care and maybe not been able to get it. We are looking for youth voice focus groups, and we are looking for tribal voice focus groups, and really just to get together. Ideally, I have read the report beforehand. It's fairly technical, so if people need support with that, happy to figure out something to provide that level of support, and just get people's feedback on what next steps should be, right? Where are the priorities as far as what recommendations are in the report? Where do people think, well, that's not how I would have said it, right? How is it landing for folks? And that will help us figure out, are we moving forward to a legislative strategy, most likely in 2025 on some of the recommendations from within the report? Do we need to go back and do another process, right? So we're just looking for additional engagement of affected communities, whatever that looks like. Folks whose families don't speak English at home, I know is a particular group of folks who have had a hard time engaging with residential behavioral health treatment. So if you know people who want to be involved, it would be great if you would have them reach out to me. I'll put my email in the chat. Unfortunately, we don't have a whole lot of staff at the System of Care Advisory Council, so it's me who is managing that. And then we're also going to be reaching out to different advocacy groups and not advocacy groups specifically, but like family voice groups. So Roberta, love to have your engagement if you're interested, and the group of folks that you are working with, right? Just to try to get a robust involvement from folks who really know how the system has affected people, so that we can move forward in a way that is centered on that lived experience and not as much on sort of what agency folks think or what providers think is the right way to solve some of these challenges. So yes, I can pull up a link to the report. I didn't have that ready, but give me a minute.
Yeah, I didn't mean to put you on the spot. I apologize, Anna. I just didn't want to speak for the council, so I wanted to make sure to give space.
Let's see. So it's a weird looking link because it is like a download the PDF link. So if you want to just go and, thank you, Roberta, download the report, it is there. Or if you're trying to navigate to it with a website, web link that's a little bit easier to read, it is there. And then the top thing under reports and recommendations. The top link under reports and recommendations. And we will be convening a conversation at the System of Care Legislative Committee meeting to see if agencies are going to be working on any of this stuff as well on, I believe it is September 6th. Yeah, so that's September 6th. And that web link I will also share if you want to join that meeting. It is available online, it's a public meeting. It's at 8:30 in the morning, unfortunately, not the most convenient time for a lot of folks, but
Any questions for Anna? All right, thank you, Anna. Any other announcements from folks that would be helpful for the group before we go into our tracker?
Yes, I would love to announce that the families in child behavioral health policy group is meeting. We now have a regular meeting time, so that was exciting. We had, I think, 23, 24 people at the last meeting, and we were talking about family supports. So thank you to those of you here who have joined that group, and if you're interested, please feel free to reach out to me with your email, maybe in the chat, and we can add you to that. So I see Sharon's here, and Roberta has been a part of that, and others who we see regularly here. So really excited to have started those conversations. The focus of that work at the moment is around the around strategies for the next iteration of our roadmap. And so we're taking different themes in different months and just exploring what's already known and thinking about whether that's still appropriate and what else we need to add to family recommendations for that plan.
Great, thank you, Hillary. Any other announcements? You can also put announcements in the chat too around, again, other times or ways to engage or events or trainings, anything like that. All right, hearing none. So we are going to talk about our CSAC recommendations tracker. So we, again, just context, had a group of folks from the Black community that came in March and talked to this group around recommendations and experiences that they have had with the children's behavioral health system and made recommendations. We had a further discussion in May where some additional recommendations were made. And what we've done is develop a tracker for this group on those recommendations. We've linked where applicable to the roadmap that Hillary was just talking about, and then have provided staff in our unit and across OHA have started to provide updates on efforts that are currently or about to happen as it related to those recommendations. We have also started to pass on some of the feedback and recommendations that don't fall under children's behavioral health to our partners and other child serving agencies or other where we feel like some of the feedback would be most helpful, heard by other groups for the work. And so we wanted to both bring back the visual of the dashboard of sort of where we are with progress so that you all can see that, and share the link to the smart sheet. You all have access to write notes, ask questions, and in this document. So this is really a shared document between OHA and CSAC to make sure that we are holding ourselves accountable to the feedback that this group received and doing follow-up and making sure that these recommendations are listened to and followed through on. Thanks, Tamara. So she put the recommendations in the chat. It also will, these recommendations will also go into what Hillary was talking about, is that, you know, as CSAC and OHA work on these recommendations throughout the next year, these recommendations can also be woven into the 24-28 version of the roadmap. So they won't be stay separate, right? It needs to be incorporated into the work that OHA is doing. But for now, we really felt like it needed targeted attention given the recommendations came to this group in March. So I think Tam, you have it pulled up because Sam's having bandwidth issues, the visual dashboard. And this is evolving. So I just want to name that this dashboard and how we're tracking, and we're learning as we go with you. So any feedback is 100% welcome. on how we're tracking or categorizing or thinking about the work. So Sam, I don't know if you want to come, if you are being able to be heard with your technology woes, if you want to walk us through this.
Yeah, absolutely. I'm going to leave off my camera, so hopefully my voice, you'll be able to hear me. I put together this dashboard based on the tracker. So we have a few things like up on the left, like the number of recommendations and just like kind of where those are sitting. So we have, you see there's 49 total recommendations, 20 of them are already on our current roadmap, which is fantastic. And then we also have some other categories that some of them need a warm handoff to another agency or need a warm handoff within Oregon Health. Within Oregon Health Authority. I put some quick links up on the left there for everyone and some contact information. And if we scroll down a little bit, the recommendations that need guidance from CSAC. So this is only the recommendations that we need your help on. It's not the entire list of all of the recommendations. And I'll provide a link so that you can go directly and see them all if you want to. But I thought that it would be particularly for the use of these meetings, to take a look at things that we need to talk about as a group, that we need more input to proceed. And then just a little bit further down, I just put together a little graphic of generally speaking how things are going right now. As you see, like there are a few things that require other departments and departments and factors that we're waiting on to get work done, but we're paying close attention to anything yellow and red because we know that those need attention. And so we flagged things in that manner, just, as a visual for us to know like how we're doing and what we need to pay attention to. And then additionally, I just added a little extra information. I put together previous presentations. I didn't put newsletter articles for Holding Hope in there yet for CSAC, but I would, something we've talked about is doing something that we've been thinking about calling the loop, where we are talking about something in CSAC and then taking recommendations and doing work, making presentations, and then following up and putting that in the Holding Hope newsletter. So hopefully the 3,000 plus subscribers who obviously don't come to CSAC will know the work that we are doing. And that's what we have so far. I hope it is useful, and it certainly I'm pretty happy with it so far. But I'd love any recommendations on the recommendations tracker, or any feedback would be more than welcome. I could put my email in the chat. Thank you.
Thank you, Sam. Any questions from the group of the tracker and the updates? And we're trying to have staff update this before each meeting so that, when we share it here or link to the document, that if there's been any further progress or additional information or delays, as Sam said, that we're being transparent. It's part of our transparency and accountability with and for you. Any thoughts? All right, well, hearing none, don't hold back. If you suddenly are like, I want to see more on this, or that isn't as comprehensive as I'd like, or I want to make sure I have, as Anna said, like Smartsheets isn't for everybody, and navigating through some of these things. If you want more time with any of us to kind of walk through this, or sort of what we're doing, or even talk through the work that's happening, we're all willing to do that. So wanted to name that. So one of the recommendations was around addressing bias and diagnosing in our system. And that could probably be its own roadmap and plan within behavioral health itself. And so we wanted to pick from the recommendations and from the feedback we heard in March, and maybe have that be thematic, right, for the next few meetings, where we dive into one, both to think through about bias with ourselves and with this group, but then also hear presentations around data, qualitative and quantitative data that we have about the children's behavioral health system, with that thought in mind around bias. How does bias show up in data, in our services, and in our system? So we are incredibly, so that's the connecting of the dots that we're going to try to do, right? We're going to take this recommendation, noodle on it together, but then also have a presentation about what we're hearing from community, and then trying to put it together. So we're also going to ask your feedback at the end of this meeting if that kind of flow for the next few months feels good. So we're going to give it a shot today to, again, connect the recommendations to a conversation of how we show up together and a presentation on the system, to see if that feels good to CSAC and feels productive. So we'll have a survey at the end, but if you want to also give feedback during, especially if you can't stay for the whole time, please, again, we're completely open. As the smaller work group comes together and figures out what CSAC is going to look like in 2024, we want to map out these meetings to be meaningful. So we invited Deshanta, who is a part of the Oregon Health Authority in our equity and community engagement team, to come help support our conversation together about bias. And she's going to walk us through a conversation, and then we're going to go into small groups, and then we'll come back, and then we'll have our presentation from the MISIP survey data. So that's what we're going to do. And welcome, Deshanta. Thank you.
Aw, thank you. And thank you so much for inviting me to talk about bias today. I'm always a little nervous when I start presentations, even though sometimes most people think that I'm super outgoing and I'm not afraid of anything, but my heart's pounding through my chest right now, mostly because this is a group that I haven't engaged with before. And so it's a little bit nerve-wracking when I'm like, oh, but I don't know if people are going to take me the way that I want to be presented to be taken. So just wanted to put that out there to the universe. So if I stumble a little bit, I tend to talk super fast when I'm nervous too. So I am going to try to be very mindful of that and slow down, but would also appreciate gentle nudges to just be like, hey, we didn't catch that, Deshanta. And also another fun fact is that since I am from Memphis, Tennessee, Arkansas area, and I came back home, and it's so funny because if y'all listen, y'all will hear my Southern drawl come out. And so everybody's been noticing it, that it's gotten thicker since I've gotten home. So if that happens too, it's not just me just not knowing who I am or where I am. It's just that I'm being reacclimated to home. I'm being surrounded by my family. And so of course that's very influential on how I talk and how I show up. So anywho, without further ado, I will start sharing my screen. I just made a really quick presentation, and we're just gonna just talk a little bit about implicit bias today, the kind of like the neurological pieces around it, and then that will lead us into our conversation later. So let me get to sharing. All right. And so y'all see my screen, and do y'all see this little thing over here where I see people, or no? Or is that just for me?
That's just for you.
Sweet. Okay. All right. So yeah. Again, thank you so much for allowing me to come and present to you all today around bias. My name is Deshanta. I use she, her pronouns. I am the Behavioral Health Equity and Community Partnerships team equity strategist. I'm about to go into a title change. Of the biggest project that I hold right now is around culturally and linguistically specific behavioral health services. And so I manage a program. And so I think my title is going to change soon, but my world is around all things equity, inclusion, access. And yeah, I don't like to consider myself a subject matter expert, and I rather consider myself like a jack of all trades. Thank you, Chelsea, for turning into a moo cow. That kind of calms me down, makes me feel a little bit more comfortable that I can stumble and I'll be given grace. So thank you. So this is just basically what my quick presentation is going to go over. I'm going to do a purpose setting with a quote that I'm going to share with you all. Then I'm going to go quickly through the art of community and then jump into the conversation around implicit bias. We'll go into that group discussion and then we'll close out with another mind model called the 4 A's. So so when Chelsea, myself, and Hillary were talking about implicit bias, I was thinking to myself, like, how do I want to present this information to this group? And I'm very relational. I you know, music, quotes, things that talk to me and help me like see the world is very useful tool for me. And so I chose to use this tool for you all as well. And I would welcome somebody to come off chat to read the quote.
Pick me, I'll do it.
Okay.
While implicit bias is always at play because all humans have bias, inequity can occur simply through homogeneity. Is that how you say that word?
Homogeneity?
Homogeneity. Okay. If I am not aware of the barriers you face, then I won't see them, much less be motivated to remove them. Nor will I be motivated to remove the barriers if they provide an advantage to which I feel entitled.
Thank you so much, Jill. So as we're going into this conversation about implicit bias, you know, there's a difference between implicit and explicit, right? That explicit is those things that we see and that we understand and we recognize it. Like your explicit bias is like, oh, I don't like chocolate chip cookies just because I don't like chocolate chip cookies. That's maybe because I've eaten a lot of chocolate chip cookies and they're just not really tasty to me. I don't like the texture, but those are those implicit things, the ones that we're very aware of, something that's, you know, they're more of your preferences, right? When we think of the implicit biases, those are the ones that are rooted in us. Those are the ones that were developed when we were really young. I mean, I would venture even to say that they could have been passed down in genetics, you know, if we really wanted to go and nerd out about it. But for this conversation, we'll keep it super simple. But those are the ones that we don't really have control over. They're just those ones that are kind of like they're there and they kind of pop up during times of stress or during times of, you know, being put on the spot. And so we'll talk deeply about that today. The first mind model that I want to share with you all is called the art of community. So that's something that we've been doing on my team in the Behavioral Health Equity and Community Partnership team. And we've been sharing it across the OHA to help us align and be calibrated in conversations, especially when we're having really difficult conversations. They're similar to like community agreements that people tend to make when they start meetings, but we wanted to provide a tool for folks for if they didn't want to create community agreements, at least they could have something that like a template to go by with some really good thoughts to share. I mean, some really good thoughts to think about as we're approaching conversations. So I will just be quiet for a minute and let you all read over this. And then I would invite 1 or 2 people to either come off of mute or put in the chat one that they would want to lean into today as we're moving forward in this conversation. So I would invite a couple of people to come off of mute and also people to just throw in the chat, you know, one that they would want to lean into today as we continue this conversation. So I will start us off. And today I'm going to lean into, we slow down so we have time to think and reflect. Like I said earlier, I am somebody whose brain is like, you think of those tickers that you see at the bottom of a TV screen when you're watching the news or something, that's how my brain is 24/7. It's just like constantly going. And so I have to be very intentional about slowing down because I am one who will respond, who will listen to respond versus listening to actually take in what I'm hearing. So I have to be very intentional about that. So that's something that I'm definitely going to lean in to take during this conversation. And it's okay if no one wants to come off of mute, that's fine. So we'll just move it right along.
Lots of good responses in the chat, Deshanta, too, just so you know.
Huzzah. I don't know if I can pull up the chat. Does that show up for y'all when I pull up the chat? Oh, sweet. I'm learning so much about technology today.
Yeah, you can have your stuff all over yours, but we only see your PowerPoint.
Yes. Yes, striving to be in community with one another with care, listening with the intent to learn something new, staying curious, needing each other to help to be better listeners, slowing down. Yes, yes, yes. Thank you, thank you, thank you. That's wonderful. So yeah, we do that. Again, we do that whole art of community just so we can be in alignment with one another, to be calibrated with one another. We all, I think, and I'm going to assume that we all have some of the same goals and want to see some of the same outcomes. And so that art of community just helps us, with the conversation piece. And so I really appreciate you guys for participating in that. So yeah, let's talk about implicit bias, y'all. When I think of implicit biases, I remember going to a training and the person who was presenting was like, have you ever been driving down a dark street, but in a neighborhood you weren't familiar with, and you're just riding along, and then all of a sudden you got this feeling, right? And then you just click, hit that door lock button. And they were like, so what do you think that is? And I'm sitting here just like, oh, I'm just trying to be safe, right? Like, I don't know. I don't know where I'm at. I don't know what kind of environment I'm in. So I'm just trying to be safe. And so he was like, well, think of that, like, if you go into, now take that same scenario and you just put that in a space. Like, now you've gone down a dark alley in a neighborhood where there is a huge Black population. And if you ride down the street and then all of a sudden you click that clicker to lock those doors, he was like, sometimes that can be implicit bias, because it's not that you're just thinking about, oh my goodness, I am in this Black neighborhood. It's just that, oh, I'm just gonna click that clicker. So the implicit bias is our tendency to automatically categorize people, things, situations, or whatever. So when we categorize things, that's just our brain filtering, right? That's just its way to process. And so as we're doing this, our implicit bias, we evaluate them, whether that's positively or negatively, assume they have certain characteristics, so we're thinking about masculinity, athleticism, criminality, nurturing, and based upon the stereotypical characteristic of groups, which they are automatically placed, and they're mostly unrelated to people's values, beliefs, and attitudes. So while I inherently do not think that all Black people are going to rob me, what I do know is that sometimes, because of, not because of my values, not because of my beliefs, not because of my attitudes, it's that implicit bias that really that lives in our brainstem, right? That kind of charges us to make these split decisions. Does that make sense? So when we're thinking about implicit bias, and when we're talking about like the work that we do, they're most influential when we're in snap decisions. So if we're under pressure, under stress, fatigue, high emotion, not having a lot of information, that's when our implicit biases start to kick in. They're those unconscious behavior, usually in socially sensitive situations. So like in the example on the slide, it says like, so our implicit bias comes up is like, if we hop on a bus and we think about which stranger we're going to sit next to, right? I'll be completely vulnerable and transparent. So if I hop on a bus full of strangers, I'm generally probably going to gravitate more towards women, right? And gravitate, not because I think all men are trying to harm me. It's just, you know, again, something that's just unconsciously there. I'm making a snap decision, and that's my brain trying to keep me safe, right? So yeah, so those are the times. So that's also when they're most influential. They're also most influential during ambiguous judgments. So when you're thinking about if you're in an HR position, right? And you got two qualified candidates, both like are like neck and neck. They're right here, right here. A lot of times our implicit bias is going to show up if we edge one person out of the other. And so it's in those moments where we have to be super aware of our implicit biases. And it takes work to change those, because they're like habits, but not habits, but they take work. You know, it takes months of trying to change, like, oh, you know, I don't have to, that is something that's coming up for me. So implicit bias is also influential during snap decisions, unconscious behavior. I've already said that. And then here's the kind of the nerdy part about it. So we're talking about it from a brain standpoint. So you think of your brain, right? This is our brain. This is our brain stem. This would be our limbic area. So this is where our relationships live. So our brainstem is what regulates us. That's what's keeping us alive, right? That's the thing. That's our autonomic systems, helping us breathe, helping us keep our heartbeats. Our limbic system is what's relational. That's what keeps us in community with one another. Those are the things where you're thinking about how I want to be loved, how I want to be seen. And then our prefrontal cortex is that reasoning, that front part of our brain, that executive functioning. And so when you think about implicit bias in our brains, so what happens is when we're not regulated, so we flip our lid, right? Our executive reasoning's gone out the door, right? If we're not regulated, if we can't relate, now our limbic system's gone, and we're solely operating out of our brainstem, and that's where our implicit biases live. And so one thing that I wanted to hit home is that in our environments, our work environments especially, so these places where we're making these really tough decisions, where we're really thinking about, who's being impacted, who's being left behind. If our spaces aren't regulated, then going back to that, that flipping of the lid. So if I don't feel safe at work, if I don't feel like I have the support at work, so I flip my lid, whatever is high pressure, I no longer have that executive functioning. So, or if I don't have people that I relate to at work, people that I'm not feeling safe with, now I don't have that limbic system online. So now I'm operating out of my brainstem where my implicit biases lies, and that's where the challenges are. So that's what we need. That's what we want to regulate, right? So now we can go into our groups, and then we can answer these questions. So where do we see biases in our healthcare system? Can we think of an example of how implicit bias have impacted you or a decision that you have made? Or are there parts of your job or decision process that are vulnerable to the influence of implicit bias? So I'll stop sharing, and then we'll go into our groups.
Jonta, will you share them again?
Yes.
Just so I can write them down.
Yes, ma'am. I'm gonna put them in the chat.
I'm sorry, I forgot to resume the recording for that last part. Thank you so much, Deshanta.
Yes, thank you.
Thanks, Deshanta. All right, I'm having computer issues. Just, keep the theme of technology being challenging. Hopefully you all can hear me. So can you reshare the link for the Jamboard, just so people can go in and see? There we go. Thank you. I hesitate to open it up to try to share, but Does anyone, as we move, is our presenter here, Rebecca? I want to make sure that we're mindful of her time, but I also would love to give a little space if other groups either want to share or talk about their experience of this conversation.
Rebecca is with us.
Oh, good. Rebecca, can you hang on for a few more minutes with us?
Yeah, absolutely. Chelsea, this is Rebecca. Take your time. I'm
Thank
flexible.
you. Oh, you're so sweet. Thank you very much. So any thoughts or feedback on this conversation or the small groups? I'm trying to pull up the Jamboard.
Chelsea, do you want me to pull it up so you don't have to, if your computer is
Sure.
having
Yeah,
its
I might.
moment?
It's having its moment. It loves it when I'm actually trying to present or lead something. Yep. Gets very angry at me.
Did you want to share it on screen?
Yeah, I just thought it might be nice because I know I didn't want to necessarily go group by group to share out, but it might be helpful to see the Jamboard just to see if themes came out of the conversation. It's helpful to us as well as we look to, develop the agendas and time together for the next couple months together of just making sure that, oh, look at all the cookies. That's so fun. Yeah, just looking to further the conversation in each meeting. So. Oh, I like that cookie too.
I'm just kind of scrolling through. Is
Mm-hmm.
that
Yeah, it's great.
okay?
Yeah. Yeah, if anyone wants to highlight anything that we're seeing or come off mute, that you are welcome to do that, or we can just sort of look through these and learn from each other.
I have been thinking a lot about women in healthcare broadly and women of color specifically, and the way pain is accepted in women. So there's a note here that made me think of that, kind of calling it out specifically around women of color.
Yeah, and the one around diagnosis, and it's sticking related to a little bit of our conversation too. Around sort of the dominant culture of our field, and then how that shows up in diagnosis for different populations.
Are these Jamie Dodgers, Hillary?
That's what I was going to ask too. Are these your cookie, Hillary?
This is my cookie. This is my room.
There it is. I love them. They're great.
The ones you buy in the store don't look quite as good as that, but those are really nice jammy Dodgers.
I just love their name so much. So yeah, children not really listened to or heard, often talked over by providers who may assume that they are too young and will incorrectly diagnose and or not provide any treatment. Yeah. I think we've heard that a lot from our youth and young adult engagement of being worried around electronic medical records or other information in school files that follow them, and them not having knowledge of or voice in how they're being summarized and characterized as they move either within systems or between systems. That's been a consistent piece of feedback that we've received. And for example, one of the recommendations we had from our parent policy group as we were building the roadmap was not wanting to repeat the story, right? Every time you go into a new care provider or have a new therapist or a new doctor, the parent feedback was, I don't want to tell the story again. That is traumatizing in and of itself. And the youth feedback was, I want people to ask my story because I am part of that story, and I don't want to be my file or my diagnosis or the story that's following me. So those were two pieces of feedback around that we continue to untangle with all of you.
Roberta is raising a physical hand, not a little digital hand. So
go for it, Roberta.
I think that one of the areas for implicit bias that we've been seeing a lot of lately is the fact that folks automatically assume that people, youth especially, but people with developmental disabilities don't have the cognitive ability to participate in their mental and behavioral health care. And so that's, you know, they just say, oh, well, you're DD or you have intellectual disabilities, therefore we'll just talk to your caregiver instead, rather than addressing them and treating them as the human that they are.
Yes, absolutely. I mean, long-standing bias in the field of mental health, for sure.
This is Kirk. I'll just share, my perspective. I can say my practice in the 30 years as an organ child psychiatrist has changed so much. And I think number one, families actually, they want an accurate diagnosis. They want to understand why their child is doing what he or she is doing. And it's also so important to recognize that a person is more than a diagnosis. And I can say that each of the families and youth that I work with really get that sense that I'm looking at not only areas that need to be addressed, but really what they're doing well, what they're really interested in, and wanting to be practically helpful. So I can say I think it's important not only in psychiatry, but all of mental health, and whatever way the children's mental health team can see that happens, that we want accurate diagnoses, but also going beyond diagnoses.
Yeah. Absolutely. Well, thank you again, everybody. And we'll, go ahead.
I feel the need to speak about the participation in research in healthcare, unless if this is more, we're talking more about the medical side, but I think we need to talk about the research and inclusiveness of different racial groups in research, because what the population that is researched impacts what the outcomes are of the product or whatever it is that is considered now the formal or the standard. But we do know that there is usually a hesitance around Black people participating in research. And at the end of the day, though, the products that are released on the market are supposed to be used by all these people. So I just wanted to mention this particular one, because as I think as a group, it is important for us to be aware that if research is not inclusive, then the product that is on the market, whatever it is, or the standard that is on the market is not as inclusive.
Absolutely.
And therefore it represents bias in that sense.
Yeah, and we find that also with our, the term evidence-based practice as well. Yeah.
I have my hand up, so
go ahead.
If somebody's talking, I can talk.
Please.
Yeah, I wanted to talk about something similar to what Carol just shared. But I wanted to say that the medical field is highly regulated, and professionals who go to training and practice follow guidance, instruction, regulations, and that constitute the bias. It's something called structural bias. I don't know if you're familiar with. It can be institutional bias. So that one, it can be either explicit or implicit. Explicit because people know they will even defend why they are making this choice or this decision, and they will refer to the regulation or that is prescribed in the field. But most of the time when you ask them where that prescription is coming from, where that regulation is coming from, they don't know because they joined the field and everything was already set in stone for them, and they are asked to follow those guidances. That's become part of the bias that are used in the medical field and the health sector. And it is important to know that it's about the system, the institution that set rules, guidance, prescriptions for people to follow. And you know that if you don't follow it, you may lose your license or if there are problems. Right. So, and being aware of that is very important. And now, who are the people responsible for those prescriptions? I think we need to discuss that. They are like legislators for the field. And then, if they need to reshape their mindset and so that they come up with new ways of prescribing things for the professionals. Thank you.
Yeah, thank you. And I think what you're speaking to too is some of the responsibility we have as employees at state agencies that have access to or ability to change some of that scaffolding that can then play out in the way you described on the ground. Yeah. Well, thank you everybody for participating in the conversation. We're going to keep this conversation going with, your feedback of how the meeting was run today. I want you to hold the definitions that Deshanta gave and the conversation you've had as we hear a presentation on survey data that we receive from Medicaid folks who have received behavioral health services in Oregon. And I will not try to fully explain it because Rebecca will do a much better job than I will as she presents this data to us. So Rebecca, I invite you to come on camera and introduce us to the topic and make us more wise than we were.
Oh, thank you, Chelsea. And it's great to be here. Thanks for the invitation. And nice to be with you all today. I was able to join in for the last 10 minutes, 15 minutes or so of your discussion on bias. And I'll talk a little bit about that today in my presentation. Let me go ahead and start sharing my screen. I will share the slides with Tamara at the end, so you'll have access to these. So don't feel like you need to take notes if you're that type. You can have access to these and access to me as well if you have any questions. So I'll just go ahead and jump in. If you do have a question, I can see the chat, but I might not be super responsive there. So speak up if you do have an urgent question. Otherwise, there will be time at the end. But as Chelsea said, my name is Rebecca Gould. I work in the Office of Health Analytics in the Health Policy and Analytics Division of OHA. I manage 2 surveys, one of which is the MISIP, which is an acronym for the Mental Health Statistics Improvement Program. Today, I'm going to give a little bit of overview on methods. I'm going to share a little bit more about bias in the methods section, and then some results. This is from our 2022 survey that was collected in 2022 with a look back into 2021. Just a quick overview. MISIP is a survey that looks at patient or member perspective on the healthcare, mental health care services they receive. It's really valuable. It's a valuable part of annual reporting for a mental health block grant. And as well, it provides a unique way we can track over time the perspectives, the member voice, and the experience that people have receiving the mental health care services. So it's really a valuable resource. some quick methods. So as Chelsea mentioned, this is a survey of people who have Medicaid who receive mental health care services. It's there's different versions of the survey that reach out to adults, youth, and families of children who received 2 or more Medicaid funded mental health services in the past year or the previous year. There's an adult outpatient survey, an adult residential survey, and then today I'll focus on the youth services survey, which is to youth who are 14 to 17 years old, and then a youth services survey for families, long name, we call it the YSSF. It covers children and youth who are 0 to 17, but their parent or guardian complete the survey. For all of the youth who complete the YSS, a survey was also sent, a YSSF was also sent to a parent or guardian. So we have several matched surveys of a youth and a parent or guardian. For the 2022 survey, it was completed in April through August of 2022. We do conduct the survey annually. In this version of the survey, everyone got a letter in the mail. They had a QR code to complete it online. There was a paper version available. They could also call in and do it on the phone. And there was a $10 incentive for completing it online. You can see there at the very bottom, there were about 2,500 total youth responses. So these two surveys combined, and an average response rate of about 17%. Just a little bit about the sampling that we use. So we start with a list of all of the children or youth from Medicaid claims that meet the criteria of 2 or more mental health care encounters services by claims. From that sample, especially for the YSSF, it's a much larger sample, or it's a much larger universe. We'll choose a representative sample. For the YSS, so the 14 to 17-year-olds, we use the entire cohort. There's not a sample pulled, we just use the entire cohort because it's much smaller. There are oversamples built in to the YSSF as well as the adult outpatient survey. We focus on making sure we have enough response from all the CCOs. We sample by CCO, but we also have oversamples for all non-white groups. So Black or African American, Asian, Native Hawaiian, Pacific Islander, American Indian, Alaska Native. We make sure that we are oversampling. We're choosing more records to make sure we get enough boost in those groups. Let me see, there's something here about open card. Oh, fee for service. Is open card the same as fee for service? I am not as sure on that.
It is.
Okay, thank you.
Yep.
Yeah. I know that in our current year, we're sampling on fee for service as well. I don't believe there's an oversample for fee for service, but they are included in the sample, and we have the ability to look at the results separately. I don't think that is highlighted in the current report, but we can look at that in more detail. And actually, I got an email today about someone who's doing some work in that area. So I think that's something we'll be working on in the future. But thank you for highlighting that. I did list just a few types of common bias in survey research here and some of the ways that we're working to address those in the MISIP surveys. One common type is recall bias. And this is an issue with MISIP because the time frame that the survey covers is really about a year and 4 or 5 months. When people get the survey in the mail, it could be up to a year and 4 months ago that they had their service. So recall bias has to do with the length of time between a service and when they're asked about it, and memory can be fuzzy. Also, people tend to remember things either on the extremes, either it was really, really good or it was really, really bad. So there's not a lot we can do about recall bias. The one kind of saving point is it's the same every year. So we might not have the truest version in that year, but it is tracking and collected the same way over time. So that kind of mitigates against that. Selection bias would be if you're selecting people in a way that isn't representative. We really work hard to make sure that our samples are representative. We're refining our oversample. We've increased our sample sizes. And again, we're oversampling by race and ethnicity groups. So the selection bias is pretty low in the design of our study. The other really common type of bias in survey research is non-response. So the type of, if there's anything unique or distinct about the people who typically don't respond to the survey. We're doing several different things to try and encourage people to complete the survey. This has to do with response rates to some degree, but specifically by certain groups. So we're continuing to use incentives, and the incentives are for online use, but also for any youth that completes the survey, whether no matter what method of survey they completed. There's different modes, which is the online, the phone, or the mail, different ways people can do the survey. They're more likely to, different reminders and language options. So there's going to be types of bias in the survey, but we do work hard to reduce it. Also, I think it's important to remember that surveys, again, are a subset of people that are trying to be representative, and it's not the be all end all of everyone's experience, but it helps us measure over time and at a high level how things are working for people. This is just a slide that gives a quick outline of what's in the surveys. I have links throughout the presentation at the end to our website and to the reports themselves, where you can look at the full questionnaire. The main core part of the MISIP surveys are domain questions. So it's individual questions that collapse and add up to scores for these topic areas. So for the YSS, which is the youth, 14 to 17-year-olds, there's 5 areas there, and these are tracked over time. They are reported to SAMHSA every year. I'll have some charts with them. And then for the YSSF, it's the same 5 with 2 additional. Over the years, OHA has added additional topics to the survey around living situation or school attendance, trauma. We added telehealth in the 2020 survey with COVID-19 pandemic. And it's been interesting tracking how telehealth changes throughout the years, telehealth use, utilization, and satisfaction. And then also medical care and coordination of care. So there's quite a few topics in the MISIP surveys. This is just an example showing the individual questions that make up the domains. And again, I put links right on this very slide. You can go and look at these in more detail. I will have in some results slide, we can look at rates by the high level domain, as well as each individual question. So that's kind of how these variables are structured. And then these are the individual questions for the 7 domains for the YSSF. I'm not going to linger here too long. Again, you'll have these slides, so you can go back and look, but these are the questions that the parent or guardian answers, and it's a 5-point scale with a don't know or refused option. So they can agree strongly to disagree strongly, anywhere in between. All right, so that's kind of the end of my methods. I'll jump over to some findings now. We'll start with the YSS survey. In the 2022 survey, we had 687 respondents, and that was about 17%. This is a breakdown of the the respondents' self-reported race and ethnicity in the survey, and showing how many were done online versus paper. And then just a small number were completed in Spanish. However, there were 16% of the people that identified with a Hispanic ethnicity. So that's a point to note. Okay, these are those 5 domains over the past 5 years. So the far right is the 2022 measurement year. If you're looking at the access and cultural satisfaction numbers, access is the lighter green. They line up there at the end, so it's hard to tell. you can see that there are asterisks on 2 of those trend lines for general satisfaction and treatment outcomes. I know it's kind of small, not the best graphic, my apologies, pulled it out of the report. But those asterisks means that there is a significant trend over the 5-year period. So treatment outcomes, they're rating it significantly lower over the 5 years, and general satisfaction is also lower over the 5 years. We did look at it by the race and ethnicity groups, and at the high level domains, there were no significant differences over 5 years in any of the domains for the YSS survey group. All right, I'm going to move on. In our appendix, we have each question that builds out the domains split out by different demographic groups. And this is a chart that I transposed the data and made it a little easier to read. It shows the 4 questions that make up the cultural sensitivity domain and break them out by race and ethnicity. There are some differences among the groups, but they're not statistically significant differences. So while it's really interesting and helpful to look at how different, the averages of these respondents rate, there's not a statistically significant difference. So even though the numbers may be different, they're not true differences. And that has to do with sample sizes and the power of the statistics. I'm happy to answer questions there if you have any. We will see some differences in the YSSF on a similar slide. This is a screenshot of that table, just so you know what you're looking for. So it has the domains down the left column with the race groups across the right. We did have a fairly small number of Native Hawaiian Pacific Islander responses for the YSSF group. So you'll see that there are dashes across or all the way down the column there. And then on the right is a hyperlink that will take you directly to this table in our report. I put in a slide as well about the CCO specific domain results, and this is a good place to show how sample sizes for different CCOs can impact to something significant or not. So you'll see there's little green arrows, and they indicate that a rate was significantly higher when compared to other CCOs. Oh,
Rebecca, before you go on.
Yeah, thank you.
Just going back one slide. So the summary of that, from just to call it out, was that so people from different racial groups all felt around about the same about services. It didn't pull out any differences between groups. Is that what this says in summary? There were no significant differences. If you were someone from the Black community, you weren't feeling less satisfied than if you were someone from a white community. Because I think it's quite a significant finding of this report, because in a lot of the things that we're talking to families about, they're pulling that out, but in your bigger data set, you're not finding the same trends.
Yes, Hillary, I think that would be correct. And I don't want to make any less the individual stories that people are experiencing. I think it's very real. And I'm sure those people with those experiences are in the data set, but as a whole, over the full data set, over all of the responses, there wasn't a statistical or a mathematically different result. So they were all rating it the same. So within cultural sensitivity, this 88% here, it wasn't different for, we can look at these. I mean, this is a good example, or this one, the 13, staff respected my family's religious or spiritual beliefs. There's some variance here, a low of 81, a high of 92. So there's a little bit of a spread there, but because the groups might have smaller numbers of people, it wasn't showing a strong correlation that one group had more or less agreement with that statement. Sorry, I'm using a lot of words, but basically
Yeah.
Hillary, what you said is absolutely correct.
Okay, I just wanted to sort of pull that out because it was surprising to most of us looking at it, given the feedback that we get in focus groups. So
Sure.
It's doesn't mean we don't have work to do, but it's just interesting it's not shown up in a survey.
Yeah. And I will say as well, we have to remember, let me click back a couple slides just so you can see the numbers. We surveyed 4,000, almost 4,500, and we got responses from 687. So while we use the responses from those 687, we have to be really cognizant that there's a lot more people who we didn't hear from. I don't think that limits that we shouldn't use a survey, but we just need to keep in mind that we're not having a census where we get everyone's response.
And I'll be interested in your thoughts on improving the response rate.
Sure, I can talk about that a little bit. I will say overall the response rates for the MISIP surveys over the past years have really ranged from about 15% to 25%, depending on the year and the survey group. So this rate of 17% is right in line there. It's pretty comparable to rates for similar survey research projects, and it reflects an overall decline in response rates across the board for surveys in recent years. One of the big challenges is changing methods of communication. There's increased use in social media and in-app messages, cell phone only households, people who may receive a phone call and don't know the number, don't even answer it. I fall into that. So there's an overall decrease in survey engagement across all types of surveys, not just mental health surveys. And for some groups, especially I think in MISIP, a potential survey fatigue, where certain people or certain groups of people are surveyed every year and they may be tired of answering similar surveys year after year. So some of the things that we've been doing are, and I think I mentioned this a little bit earlier, but really refining our oversamples, really trying to get enough people to receive the invitation to answer the survey. We've increased our sample sizes. We used to have smaller samples we started with. Now we're using more of the whole group. We've revamped our survey invitation letters, and I think I mentioned as well, we're changing the incentives so more people are eligible to get them. We even were talking about, even if people complete a certain portion of the survey up to a certain point, but maybe leave off 10%, they can still receive an incentive. So we're doing some things to help improve response rates around that.
You've got a couple.
What I'd recommend, sorry, Hillary, what I'd recommend is writing those down and then getting input from CSAC maybe at our next meeting about what might be further done to improve the response rate.
Yeah, I'm happy to have your input or your thoughts on response rates. Mm-hmm.
The other thing, one of your slides looked at the different CCOs, and I see entire CCOs not having anybody. Do you have a sense of that? I saw Trillium, for example.
Oh, so the way that this is set up is, and again, the YSSS survey is one of our smaller ones. So you can see across the very top row, the total responses. They didn't report if it was less than 30 people in this report. So that was a small number suppression. We did have responses. They're just not included in this table because of small numbers rules. We have the data though, and can look at rates. They're just not published here because of small numbers.
And I don't mean to take up too much time on this, but I would recommend giving each of the CCOs feedback in terms of their response rate. That's one example, as well as overall results, which might be a part of quality improvement on each of the CCOs part.
Yes, thank you. We do have individual CCO reports that I know are made available to them, and it has a summary of all of these rates by each CCO, so we can make sure that they have those and moving forward as well. Thank you for that feedback.
And we deliberately shared this out with each of the system of care coordinators for them to share with their exec teams and others. And I know Rebecca's done one presentation with one CCO directly. So again, looking at their data. So if folks are here from a CCO or you're part of a systemic care, you're welcome to ask for the presentation so that you can deeper dive into the numbers that come up for your area. You've got a couple of other things in the chat here, Rebecca. One was,
thank you.
Do you pick up open card data?
I think I addressed that.
Okay.
My understanding is open card and fee for service are the same, and
Yes.
it's not called out in the report, but I do think we hit some of those numbers, or that group fee for service. Okay,
and Jill's comment, but everybody overall has less satisfaction and felt services were less effective over the last 5 years. That going back a couple to your line graph, I think she was looking at a decrease in general satisfaction.
Yes, and that general satisfaction is the darker green. So it started at 73% in 2018, and it's been slowly decreasing down to 66%. And that's 66% saying they were strongly satisfied or strongly agreed or agreed.
Okay, and I think the Grace Bullock has said, do you have the standard deviation data? She's wondering if there's a variance problem.
We can provide that data, yes.
Right, and it's curious that with many non-responders, whether or not there's a selectivity bias occurring.
Yeah, there very well could be. We have standard deviation data available, but it's not published in this report.
Okay, and then Mercy's asking, is the survey an ongoing process?
Yes, it's every year. We're actually currently fielding the 2023 survey right now, and we're with a new vendor. But yes, annual. It's required annually for federal reporting, and then it's also an opportunity to provide this feedback to this group and our state partners every year.
Great.
Back a couple questions. When is the 2023 data going to become available, as well as how does our state compare to other states?
Great questions. So the 2023 data, it will be available in January of 2024. We're fielding through October, and then we'll have data turnaround to us in early December for reporting, and then we'll have a report finalized and reviewed. Should be available in January. And that's typical. That's the typical cycle.
And then how does Oregon?
Yeah, as far as comparing to other states, I don't have that data readily available. The only really way to get it is through SAMHSA. They take the domain scores and compile them by all the different states and report them. I did track down a document that summarized that, and I can find that, and when I share the slides, share that with the group. I'm sorry, I don't have it available or know off the top of my head.
And it's in a report that I'll put in the chat that we created, Kirk, which is our performance indicators, where we looked at some national comparisons with the MSIP from other states. So I'll link to that, and you can see a couple of ones that we chose to pull out that were our comparison to others.
Thank you very much.
It's great because the MSIP is carried out as part of the mental health block grant funding, and so other states have mental health block grant, and so we all have to do this, and so it does all go into a database, or the majority of questions go into that database for us to be able to see others' numbers. The other things in the chat were Jesse saying the discussion about research in the Black community's justified skepticism of research may need to be considered. Jill agreed with that. And just wondering about selectivity bias from Grace. So then Chrissy is also wondering if it is really known whether the youth filled out the response and not their parent or guardian. Good question, Chrissy. Gonna put my hand up as a parent who used to receive this, and I sort of do it with my kid, but a lot of the time I would just fill it out. But you do get 2 surveys, so as a parent you clearly know which is the youth one and which is the adult one. And so I do think that often it is filled out by the youth. I hope so.
But to your point, Chrissy, there's not any kind of verification we're able to do on that. Thank you, Henry, for going over the chat. The way my windows are set up, it's harder for me to see it while I'm going. But thank you. I want to be aware of time in the meeting, so I'm going to jump ahead a little bit, or at least go a little faster. I have just slides here of the CCO, and then highlighting some differences. This is interesting because it's the same number, 77, for Pacific Community Solutions for Lane, and then also Marion Polk County, but one is statistically significant and one is not. And I'll just point you to that really has to do with the sample size, the gray row at the top, 86 for the Marion Polk and only 33 for Lane. So has to do with the sample size. You may see the same number, that one is statistically significant and one is not. Just watch for that as an example. I put in some slides showing how the cultural sensitivity, the access, the domains, the scores break out, the CCO combined, by CCO and then compared to all CCOs combined. This is just another chart showing the differences and what's statistically significant and what is not. But I'm going to go ahead and jump ahead here. It's just highlighting it. One question that we ask is if at the time of the survey, how many are still receiving treatment? And 59% were still receiving treatment. And then we asked how long they had been seeing their most recent provider. And about half have been seeing that provider for a year or more. And then if we combine these groups, over 75 have been with that same provider for 6 months or more. That's helpful to keep in mind as we think about the satisfaction of the different types of care they receive from their providers, if they've been with them a short amount of time or a longer period of time. And this is a statistically significant 5-year trend up of people that were still receiving treatment at the time of survey. We ask, excuse me, about medical care and prescription medication. So over the past year from the survey, about 69% of the youth saw a medical doctor or nurse in an office. And then they were asked if they were taking medications for emotional behavioral health problems. And there was an upward trend since 2018 of youth reporting they're taking medications. And that's about 45%. And then in 2022, we started asking a new question if they felt the medication had helped. And a high proportion, 87%, reported that their medications were helping.
That's actually higher than I would have expected. That's helpful to know.
Interesting, isn't it? Yeah. So we'll see what that looks like this year because we have the same question. As I mentioned, we ask about telehealth. This was a really important thing to take a look at when the pandemic hit, and we've been tracking it since. So in 2022, 66.8% had a virtual, which is a phone or video visit with their mental health provider. And that was 76.4% in the 2021 survey. So it's dropping, and it is a significantly lower result. We ask how they, not only did they receive, did they take, or did they have, not only if they used telehealth, but their experience with it, what they thought of it. So 56% were satisfied with virtual compared to in-person, but about the same percent, 59%, did agree that they preferred to see a provider in person. And then we saw a significant downward trend since 2020 in youth reporting that they were satisfied with virtual sessions compared to in-person sessions. So that 56%, that has been decreasing over time. And then within the 14 to 17-year-old cohort, 14 to 15-year-olds responded significantly less satisfied with virtual sessions than the older 16 to 17-year-olds. So just some interesting notes there. And there's a lot more data on telehealth in our report, more detail. So I'm going to switch gears over to the YSSF. Again, this is parents and guardians who complete the survey regarding their child's care. We had a sample of a total of about 10,000 and 1,838 responded. You can see here the breakdown by race and ethnicity. This is the self-reported race ethnicity of the child. We also collected the race ethnicity of the provider, or sorry, the parent or guardian, but this is of the child. All right, let me go ahead. Similar chart of the 7 domains over time. We can see just from a quick glance that most of these are decreasing over time, and several more are statistically significant. I know it's hard to see, but there's an asterisk on the top one: cultural sensitivity, social connectedness, the gray one, second one down, participation, the purple, and then the bottom 2, treatment outcomes and daily functioning. We'll look at these a little more detailed in the next slides. And again, it's all available in the report. So these are the cultural sensitivity questions broken up by race and ethnicity. And again, this is in an appendix, which I'll have a link to on the next slide, but this is just an easier way to see the data than it's laid out in a table in the report. So here we can see that the yellow boxes are those that are significantly lower than the statewide average, and the green boxes are those significantly higher. So for the lower, we see that for Black or African American, on the third column over, staff spoke with me in a way that I understood. That was lower at 81%. And then respecting families' religious and spiritual beliefs for white, it was lower, statistically significantly lower at 79%. Hispanics rated it highest at 90%. And then also for Hispanics, sensitive, number 15, the last column, staff was sensitive to my cultural and ethnic background. So it's interesting data. And again, like we've been talking about, keeping in mind our sample sizes and the representation that we have in the survey. I think that our sample is it works, it does the job, but it can always be improved. Let me move ahead. I won't spend time here. This is just the table that shows race and ethnicity groups for the YSSF with the domains down the left-hand column. And you can see the individual green and yellow arrows. The data on the previous slide was taken directly from this table.
And Rebecca, you have a question from Roberta.
Oh, thank you.
She has her hand up. Go ahead.
Yeah, go ahead. Thank you.
So on the prior slide, I was just wondering, so under the second column, the Black or African American is 74, but yet white people is 79, which is a higher number still, and yet it's not highlighted in yellow. Is there a reason for that?
There is. This has to do with, it's really a statistical artifact of the total number of people in that group. Number of people in that sample group, the confidence intervals will be wider. So I wish I had a good visual for you. But it has to do with the number of people that are in each group and whether or not their percentages have the statistical power and fall within the range of the confidence interval.
So 74, just represented here, is a lower than 79 and much lower than 81, but it is not significantly lower than the statewide average, right? That's what you're representing.
That is correct. That is correct. So the calculated rate is lower, but it is not statistically significantly different. It is not statistically significant as a lower rate than the average because of a wider confidence interval. I think that the result is useful, but as far as the numbers in a statistical way to think of it, they need to be taken with a grain of salt.
We had another question in the chat from Sharon around, does this data capture youth enrolled in school-based services also? And my guess would be yes. If it's a Medicaid service and it was a billed service, the sample size wouldn't discriminate where the service happened. It's just if they had the service. Am I correct in that, Rebecca? Okay.
That is correct. Yes. Thank you for your questions. This is really, really good. Including youth in residential programs. Yes, youth in residential programs are included in the sample. And one difference there is they don't have to have 2 or more residential. It's just if they had 1 residential stay, they're included. So that's a different point. Okay, let me go ahead and move on. I want to definitely answer your questions. Thank you for your feedback. Let me finish a couple points here. These are the race ethnicity specific domain results. This is a table showing for American Indian, Alaska Native, several that had higher individual questions. And this is interesting because perhaps they weren't statistically significant on the whole domain, but by individual questions, those rates were higher or lower. So we could look at a little more detail here, which I'll let you do on your own. Let me move ahead. And again, I've just put in a table, and I hope these links are helpful for you for taking you directly to that table in the report. Hillary commented earlier about how we talked with one CCO, and that was with the Marion Polk. You see there's many yellow arrows, so they had significantly lower results in several of these. So we had a discussion with them, and I went ahead and pulled out some specific rolled up domain scores on this slide, whereas the individual questions are on the previous slide. So this shows the significantly higher than the state average. And this shows those areas for Marion Polk Pacific Source Community Solutions Marion Polk that were significantly lower. Okay. Looking at the YSSF for those that were still receiving treatment, similar to the YSS, about 62% respondents said their child was still receiving treatment. Slightly different follow-up here. Of the 38%, so the half who were not receiving treatment, they were asked why they were no longer receiving treatment. And about 44% said their child no longer needed treatment. And then about 10 and 13% about the treatment wasn't working or it was no longer possible due to problems unrelated to the treatment effectiveness, and then other reasons. I have in my notes for the slide, there were 234 comments written in, and some of the themes there for that, about a third, was that OHP was no longer paying, or their insurance changed, or the insurance wasn't helping, that the provider moved, it changed, or the provider wasn't replaced, that they had challenges with communication or appointment availability, maybe it was virtual only. Another theme that they had needs higher than the level or more intense than what service was available. A common theme was that the school year ended and that the child was gone for the summer. And then kind of the last theme was that the child was refusing to participate or unable to focus. So a wide variety of reasons there in other. Similar slide we looked at for the YSS about health and health care and prescription medication. So about 60% reported that their their child's general health was excellent or very good. And this is a significant downward trend from 2018. So fewer are reporting that their child's general health is excellent or very good. About 36% of the children were taking medication for emotional behavioral health, and 75% thought that the medication had helped their child. And this is a significant upward trend in children being prescribed psychotropic medications in the past 5 years. Parents saying a little less helpful than the teens were saying about their medication. For telehealth, so 69% of caregivers reported that their child had a virtual or phone session in the past 12 months. Some follow-ups, 64% agreed that they'd like not traveling for appointments, and 63% agreed it was easier to schedule appointments for virtual sessions. But 60% also agreed that they prefer their child see in person. And these rates varied quite a bit by age, with youth ages 13 to 17 being significantly more likely to have telehealth sessions than younger children. So we'll keep monitoring telehealth, but we see that it's continuing to be less used and less satisfaction with it. I know we're past the noon hour, so I want to be cognizant of time. I'll just quickly share that we collect data on crisis and how well parents and guardians felt that the children received this support they needed during a mental health crisis. So that's what's shown on this slide. This year, there was no significant 5-year trend in needing assistance in crisis or like satisfaction when assistance was provided. But last year there was a significant downward trend. So that has evened out. So it's improved a little bit this year. So what I mean is people getting the support they need during a crisis has improved.
Rebecca,
Yes.
I don't know if you can see me. It's Jessie.
I can.
I wanted to just see, do you know, were there any comments around what another source was? Because I'm wondering if another source is like an emergency department, or could that also be like a mobile response team when those are up and running? You know, are we differentiating between those at all?
I will need to follow up on with you on that specific question. I don't know off the top of my head. I'm sorry.
No problem. Sorry to
I
ask
written
about
it
the year. That
down.
wasn't meant to be.
No, it's okay. I will find out, especially with the improvement that's shown in this data. It'd be good to know a little more detail. So I'll follow up with you on that, Jessie.
Awesome. Thank you.
Yeah, no problem. This slide, we ask a series of questions about what the caregiver expected to happen because of treatment and then what actually happened. So like the first one there is 63% expected their child to become happier after receiving treatment, and 42% said their child actually became happier. So most of these people's expectations were higher than the outcomes. But you can see some differences there. And in 2023 survey, we're adding a question here about experiencing fewer or less frequent thoughts of suicide.
Rebecca, that is a really interesting slide. And for me, it speaks of how important it is for our state to pay attention to outcomes. That really is an extremely interesting slide.
Great, good. Thank you.
Mercy has your hand up.
Go ahead.
Yes, one question I put in the chat room was that, is this survey an ongoing survey?
I'm sorry, I didn't quite hear you. My internet cut out just a second.
Is this an ongoing survey?
Ongoing, yes.
Ongoing?
Yes, thank you, Mercy. Yes, we do it every year.
So, I mean, every year for this year, has it ended, or this year is still ongoing?
Right now, we are fielding the survey. So the survey is conducted each year for a period of about 4 months. And then the following year, the report comes out. So this data that we're looking at today is in our 2022 report.
Okay.
It was published earlier this year in 2023, but it was from surveys collected in 2022.
Yeah.
Yeah.
So that
So
does not include any new thing that has to happen this year or any of last year, even for those that did not participate in the survey last year.
right. So right now, we're currently in the field. We're collecting this survey right now for the 2023 survey.
Yeah, I'm sure that that survey link is in this communication and we can access it from there, right?
The slides or the report
The link, the survey.
to complete the survey, you mean? On our website, there's information that links to the survey itself. The way that the samples are set up, people can't volunteer to participate in the survey. They have to be invited, and it has to do with the way the samples are built and the weighting. So if someone receives a phone call or a letter to do the survey, we would love for them to do it. But people can't volunteer, if that was your question.
Yeah, thank you. We can volunteers, but that's why we are not having inclusive participation of people that really have the experience to do that. Because if someone is not on this line, not everybody is on this line. I didn't know what is going on, you know. And so we who are on this line, this is my first time joining this line. I'm very happy to be part of this group, honestly. If I was giving you a chance and giving you a letter, you would hear my voice, and maybe the people themselves will be representing themselves to share their experiences. Things are tough out here. So like whoever receiving this letter, who are invited to participate in these surveys, I like to be part of that group that participate in the survey. I've been working in this community for a very long time. I've seen it, I've heard it, I've become part of it myself. And it sucks and it hurts. And I'd like to express my voice for somebody to hear it. Because I raised 2 boys myself. And the fact that when you carry your kid to the hospital, the first thing they want to give there is drugs. No more evaluation, no involving family to see how the kid is going to be helped. You give the kid that is already suffering from drugs, you're giving them more drugs. How is that supposed to help them? My name is Mercy. My name is in there. If you would like to invite me, I really love to make my voice to be heard in this kind of matter, because we are the ones that is already suffering. Coming to this country as a refugee and going to school, and everything you hear in the nursing class was the Black population is, prominent to this. This is common to them. This is common to them. How do you get all of that information? And that is the stigma that is still holding on to medical. That's what they are still carrying today. Because even in classes, they tell you that, oh, this disease is common in the Black people. This other disease is common to the Black people. It's that. Yeah, we are the disease carrier. How did you come up with that? How does that change today? The survey method has to change today. So that can change a little bit. Where people are hiding out here. We don't just want to be reading piece of paper because we don't know those people that took the survey. I really appreciate that they took the survey. What were their experiences?
Thank you, Mercy. I appreciate that. I will talk to our partner that conducts the survey and follow up with them if there's a way that we could get some information from you for the survey.
Yeah. And also we should talk about, we should try connecting with community-based organizations. They are the representative of their communities. They hear all this hurt, they hear all this pain. I can cry right now to you talking to you because what my experience has been and is continuing to be. That you can't even help someone. Thank you so much.
Thank you.
Thank you, Mercy.
one more slide, and it is just an update on the 2023 surveys. Like I mentioned, we're currently fielding, and we should have data at the end of this year and reports in January. Some changes to the questionnaires that we've implemented are in the YSS. There's questions on school attendance and school experiences. We know a lot of kids receive support from schools, so we wanted to add that. And then in the YSSF, we added a question on the length of time people are waiting for their first visit, the impact of treatment on thoughts of suicide, and then if mental health service providers ensure communication and care coordination, especially about thoughts of suicide and support. We're really excited to fully implement REAL-D and SOGI data collection standards in the 2023 survey. And we have a new vendor, so we have an opportunity to redesign and refocus the reports. So as you look through them, if you have any comments, you can let me know. We're in the process of doing that right now.
Rebecca, one of the things that can impact treatment is when agencies lose a provider. Do you have any way of capturing the turnover within agencies?
Not through this survey project. I know that's really not in the scope of this survey project. I would think there is probably an opportunity with the teams who work more with the providers listed and that are contracted with Medicaid. There might be something there. I'm sorry, I don't work directly with that, but that would be my best guess.
Are there other questions for Rebecca or reflections, comments? I know there's been a lot going on in the chat.
Can I say something? Can you guys hear me?
Please, yep.
So I'm over in Eastern Oregon. I live over in Union, small town kind of over by La Grande. We have a hospital in La Grande, and we lose a lot of providers. We have people that come through and they leave a lot because small town Oregon, there aren't very many opportunities here, and they get better pay somewhere else. And it's hard when you develop a connection with somebody, you're doing well, and then they leave. And we have a lot of that around here, and it's hard for a lot of people.
Yeah, thank you for sharing that.
Yeah.
I think we've heard a lot about turnover and a lot about vacancies of positions being open and not being able to recruit. Roberta?
Yes, could you go back one slide?
Sure.
So the impact of treatment on thoughts of suicide, I think that's really wonderful. I wonder if you could add length of time to obtain treatment as well, because not just for your first visit for any mental or behavioral health services, but also those specific to suicide or in follow-up to suicide attempts and what have you, due to gaps. Like, so kiddo goes into an acute care situation due to a suicide attempt and then comes out of that with no mental health services available for 6 months or longer is pretty significant.
That may some of that might be captured in the crisis data, but not specifically. I think it doesn't go down to that level of detail, does it, Rebecca?
I don't know that it does. We'd need to look into
the question,
the specific questions. Yeah, that new section of questions isn't quite as detailed with time that they took to receive services, and I think the survey is yeah we'll look into that.
Yeah, I think it's especially timely because we're rolling out as a state so much attention and investment on, mobile crisis and the new 988 service that's nationally available now. So I think that question will be more relevant as it relates to evaluating those services and investments and policy and program decisions as a state.
Yeah, and
So some-
Jenny's comment in the chat is very interesting in asking if there will be data taken or include in your survey anything about whether or not the youth felt traumatized by the treatment itself.
That topic is not so much included in the survey. We'd want to be careful with the types of questions we ask that might lead someone to respond. So the way the question's phrased would be really important with something like that. I'm not an expert in suicide prevention or surveying, so it would be good to know if there are resources of how those questions might be asked in a non-leading way.
Right, not specific to suicide. Just
treatment in general.
Mental health, yeah.
Yeah, now I think it's phrased as whether it was helpful or useful, I think is the terms used, but it's not asking, like, was it harmful? I think is where Jenny was going. Yeah.
Yeah, because helpful is leading because you're looking for a positive response.
Yeah, I don't remember what the term is. I'm not an
Can I say
expert in that either. Yeah, please.
Okay, so Oregon is the 17th highest rate of suicide in the U.S. But in the last 3 years, we've had a 3-year decline in youth suicides in Oregon. I don't know. I did some research on this before I decided to come in here and talk about it. But we've had decline in the last 3 years, which is it's showing that something is working. It may not work for everybody, but something is working.
Yeah, thank you. You just made some of my team members very happy that you knew that data on the work we're doing for suicide prevention, because we do try to get that messaging out.
Well, we just recently in La Grande had a young man. We have some construction going on at the hospital. We had a young man hang himself from the crane, and he survived. And he's a friend of mine, and he said, all he wants to do is live now. Like they got him in, they helped him, and all he wants to do is live, and he regrets what he did.
I will say, and certainly I've been involved in Oregon's youth suicide efforts for about 25 years. These last 3 years, the pandemic and all the implications with that can impact rates. It'll be real interesting to see how our data looks post-pandemic, first, second, and third year. So,
yeah, it's a great point. I think some of the early training and conversations we had at the beginning of the COVID response was looking at data from natural disasters and other sort of large scale crises from other countries, of looking at sort of where is the peak of the impact, and knowing that for children specifically, you often see the trauma, the response of the trauma or the impact of events like that post. And I don't know when we call it post-pandemic, honestly. It sounds like there's a new variant coming this fall, so, but I appreciate that.
Oh, sorry.
Oh, no, go ahead.
Yeah. Clearly the rates of anxiety and depression are rising in our youth associated with the pandemic, and it's had implications academically, socially, et cetera. So it will not surprise me with the associated increase in anxiety and depression if our rate increases. Another reason to pay attention to it.
Yeah, and we're going to bring some of the diagnostic data hopefully next month for all of you to look at. Jenny?
Yeah, I was just wondering if there is or will be any data taken on outcomes for disabled children versus children who aren't experiencing disabilities or disabled, like neurodivergent kids who might respond differently to interventions than maybe a neurotypical kid. Is there any data being taken on that?
I'll just add, thanks for your question. Part of the Real D, it's race, ethnicity, language, and disability. The disability questions that are part of that set are being included in these MISIP surveys, so they'll be part of the reports coming out next year. But I don't think that those go into the level of detail you're referring to about different levels and severities of neurodivergence.
And Jenny, that'll be nice too, because we can work with Rebecca to call out that, but like now that it's a new way to sort of, you know, look at the data, we can actually call that out in the report. So look, is there any statistical significant difference between those experiences or all the different questions for that group? Because that was one of the asks we had of Rebecca and the people doing the survey, was to pull out that racial group data to see if there was a difference, like was it being sort of masked within the larger group, or if there was significant difference between the racial and ethnicity groups. And so that we can do a similar, well, not we, they, those that do data could look at the disability questions specifically, or SOGI, as we're implementing that data set as well.
Yeah, and I'll also say with our new vendor, one new tool that we'll have is something called a data compendium, where it's just a big spreadsheet that lists all of the questions in the survey by many different demographics. So we'll have crosswalked by the Real D and SOGI groupings, Real D and SOGI, by CCOs, by other demographics. So that'll be a quick, easy tool that you can look at some of those numbers really easily.
Will that include the age breakout that you did on one of those questions? Yeah, that's awesome.
Age breakouts, all sorts of different demographics. And I'll have some drafts of those that I can share with some of you who are interested in providing feedback.
All right, Grace, we're going to end with you before we just go to open comment time before we end at 12:30.
Thanks, Chelsea. I'm just wondering, in addition to the data you're collecting, if you're also considering or have been collecting data regarding protective factors. I think it's really important for us to know what factors in youth lives and family lives help to prevent, you know, beyond prevention efforts, because I think that that's a big area that is not often considered. And if we know where the protective factors lie, then we can, you know, hopefully as a system, try to support the protective factors rather than just focusing on illness and pathology.
Yeah, thank you. I'd be interested in if you take a look at all of the different individual questions of the domains, if you think there are some there that would qualify as protective factors. I think that there may be some overlap there. So we might already collect some of that. It's just not totally, it wasn't called out in my presentation, but there's I think some data there that might fit in with what you're talking about. We haven't had any specific requests to consider adding that type of questions to the survey yet. So anytime we have asks to increase questions on the survey, we have a discussion and talk about the time cost of to the survey. You know, we're concerned about people completing the survey and response rates. And so the longer we make them, the more we're likely to have fewer people respond. So there's always a balance with adding questions that are most helpful for everyone. But
I'm also curious.
See some gaps still, we can have some conversations.
Well, I'm also curious, Grace, too, if some of that is being captured in the student health survey too, that wouldn't necessarily be needed to add to this one, but maybe over there that we could, you know, have them come, because there's a lot of the protective factors in that survey is my understanding too. So we could also, again, not have them in all the surveys, but look at those same qualitative data aspects in that survey too, and see if that's helpful. I don't know. Again, not expert.
I mean, there are some, but you know, that's a community sample. I'd be really
this is generally speaking more of a clinical sample, and I'd be really curious to see what protective factors in clinical samples we could, pull out of this and extract to see that, because in the general population, you'll get different data, obviously.
Yeah. Good point.
I'd be super interested, to your point, Grace, that a question, something around like, does your provider ask you about protective factors such as, because that would speak to whether or not the providers are looking for protective factors and fostering them in their services as well.
Yeah, exactly, Jill. I think that historically, at least, I can't speak to all practitioners, but I think a lot of those contextual factors aren't necessarily captured or included in some forms of therapy. And I think that in some ways, particularly for, non-white communities, it negates a lot of the protective factors like spirituality and, like community and things we don't necessarily consider protective factors in the mix. And I think it does a disservice to communities that have those built in where it's not recognized as important.
Well, and I think it also goes to what we've talked about with some of the data around loneliness and feeling, youth that are feeling more and more disconnected from their peers, like some of the other data that we're seeing in other surveys and other national data, showing them where some of that, at least in those surveys or those research studies, where it's declining, some of the protective factors that we typically think of. Yeah.
Absolutely.
Sometimes the most important recommendation I can make is what natural supports does this family have? And I don't think providers put enough focus in.
Agree.
Other thoughts or comments in our last few minutes together? As you leave, just before, thank you, Rebecca, as you leave, you're going to get a survey, is my understanding, to let us know how the structure of this meeting went and give you an opportunity to give some feedback and maybe a giggle. There's some phrasing that hopefully you take with levity as you give us feedback. And then our hope is for September, October, November, we'll have similar conversations and structure as it relates to, depending on the feedback we get today, have similar questions around bias as we look at more qualitative and quantitative data about children's behavioral health. And so we're learning and thinking and evolving as we go. So please give us feedback and any feedback you have for Rebecca as well. And we work closely with her and can continue to give her thoughts and feedback on this data, especially as you have time to check the website and look at and read the full report. Kirk?
Yeah, just a quick, this meeting was extremely meaningful, the entire meeting. I just want to give kudos to whoever developed it. This was really worthwhile, everybody to attend, and just want that to be acknowledged.
Thank you, Kirk. Any other thoughts or feedback or comments about cookies before we let you go into your rest of your Friday and weekend?
You just speak out. Yeah, I just want to appreciate whoever put this together according to what the previous caller said. This is a really great platform and I learned a lot of stuff here. We can't change the system overnight, but we can work towards something better. So thank you very much. I'm looking forward to the survey. Is it going to be sent to emails?
It should pop up in your browser as soon as you leave the meeting.
Okay.
And you can always reach out to any of us individually if you would like to give more specific feedback that's not available in the survey. Thank you.
Thank you. Always willing to do that. Thank you.
It would only let me join by phone, so I don't know if it'll send me.
Oh, I don't know. It did when I joined on Zoom, but I don't know if it does when you call in.
Yeah, it didn't give me a Zoom link. It just gave me a call in.
I can email you if you let me know who you are.
Jessica Raven.
Ah, yes. I'll email you, Jessica.
Yep. Thank you.